Thank you for inviting me here today. My name is Rachel McConnell. I'm a physiotherapist in Beaumont Hospital in Dublin, where we see the majority of MND patients, as Bernie was describing. Roisin Vance, Professor Orla Hardiman, and Dr. Deirdre Murray were also involved in this research. Today I'll be discussing an evaluation of the airway clearance adjunct prescription in our clinic. So just a little bit about the background and our role as physiotherapists with motor neuron disease patients. So most patients will present with respiratory insufficiency. It's the #1 cause of mortality and morbidity in this population. Patients will have an impaired cough because of inspiratory muscle weakness, expiratory muscle weakness, and upper airway muscle poor coordination and poor ability to control their glottis. So this results in an impaired cough and an inability to clear secretions. So with an impaired cough, you will get a reduced peak cough flow. So it's considered that a peak cough flow of 160 litres per minute is the critical level to clear secretions, and that a peak cough flow of 270 litres per minute is adequate for airway clearance. And to assist with these airway clearance, with our management, we use 2 different techniques. So the techniques that we use are manual breath stacking and mechanical insufflation and exsufflation. I'll just talk a little bit about these 2. So with the manual breath stacking, we use a resuscitator bag with a one-way valve in a face mask, and we stack breaths so that we achieve a maximum insufflation capacity. So this increases our inhalation volumes, and it recruits collapsed lungs and reverses atelectasis. So with the larger inhalation volumes, you can get a larger cough, a stronger cough, and also improves the lung range of motion and helps with preventing poor compliance of chest wall. With the mechanical insufflation exsufflation, this is a device that uses positive and negative pressures. And again, it uses maximum insufflation capacity, again, to improve your inhalation volumes. We generally do about 3 to 5 cycles of positive pressure, achieving your maximum insufflation capacity. And then this is rapidly switched to a negative pressure, simulating a cough, a natural cough. In our clinic, we generally prescribe the manual breath stacking for patients that present with a peak cough flow at about 270 litres per minute, and the mechanical insufflation exsufflation, or otherwise known as cough assist, for people with a more severe respiratory insufficiency, around the 160 litres per minute. But we don't have any guidelines or to, I suppose, guide our assessment or our management. So a little bit more about the evidence with these adjuncts. So the cough assist or the mechanical insufflation exsufflation can improve peak cough flows, and they can improve the peak cough flow higher than other unassisted coughing techniques in neuromuscular disease patients. It can also improve the peak cough flow above the critical level of 160 litres per minute. And in a study by Sennett et al., it showed that it increased the peak cough flow, the highest peak cough flow when it was compared to other assisted cough techniques, although it wasn't the most comfortable technique reported by patients. In a Cochrane review last year, it did say that there was insufficient research for or against the use of mechanical insufflation exsufflation in neuromuscular disease patients. With the manual breath stacking, there is less research in this area, but a study last year showed that manual breath stacking improved or increased peak cough flow significantly for up to 30 minutes following treatment. And this is very important for patients, particularly for swallowing and protecting the airways, and we generally advise patients to use this maybe 30 minutes before eating. My aims of my research were to identify the number of patients that were prescribed an airway clearance adjunct, to identify what adjuncts were prescribed, evaluate the measurements that were used to prescribe these adjuncts, and finally to determine if these were the appropriate measurements used. The methodology, it was a retrospective analysis. I looked at all the physiotherapy charts and some medical charts of the patients. I received information from the Irish MND Register, and this was over a 17-month period from January 2013 to May 2014. So the results. In our clinic, over the 17-month period, we saw 259 patients, and there was a total of 892 visits. Out of the 259 patients that were seen in clinic, physiotherapists saw 189 patients, so that's 73%. So there's quite a high demand on physiotherapy in the clinic, considering that there's only one physiotherapist. So the 73% of patients that were seen for physiotherapy, I looked at what physiotherapy intervention they've received and just divided into two, whether they had received an airway clearance adjunct or they had received other physiotherapy intervention. So other physiotherapy intervention could include mobility aids or devices, manual handling, musculoskeletal assessment and treatment. So there's quite a large scope of physiotherapy interventions in our clinic. But 30.7% of patients received an airway clearance adjunct. So I thought this was quite low, considering that respiratory insufficiency is the #1 cause of mortality and morbidity, and that there was a study by Schiffman et al. That 86% of patients at diagnosis will have respiratory insufficiency, but only 19% will complain of symptoms. I looked at what type of adjunct that they were prescribed, and the majority of patients were prescribed the manual breath stacking. 28 were prescribed the mechanical insufflation, exsufflation, and there was a small number of overlap of 9 patients receiving both adjuncts. I looked then at this is just a timeline of when the patients that received the 2 adjuncts, when they received them. So with the 9 patients, 2 had received the manual breath stacking and the mechanical insufflation, exsufflation on the same day. So that's patient 2 and patient 7. And the other patients all received manual breath stacking first, followed by mechanical insufflation, exsufflation. The average days between receiving the mechanical insufflation the manual breath stacking first, followed by mechanical insufflation, exsufflation, was an average of 80 days. So this is on average maybe 1 to 2 clinic visits following the prescription of their breath stacking. So possibly the patients had quite a significant respiratory deterioration, or possibly they should have been started on the mechanical insufflation, exsufflation initially. I looked at what assessments we use to prescribe. On the left, you have the mechanical insufflation, exsufflation, and on the right, you have the manual breath stacking. The light blue represents that physiotherapists have documented about symptoms only. The mustardy coloured is peak cough flow and symptoms were documented. The kind of greeny colour is peak cough flow only documented, or finally the dark blue that the physiotherapist did not document why they had prescribed the adjunct. You can see with the mechanical insufflation, exsufflation, that symptoms only assessed was the main reason for prescribing it, followed by peak cough flow and symptoms. So the symptoms only is the main reason for prescribing the mechanical insufflation, exsufflation, and objective measures such as peak cough flow was quite low. Reasons that I think this may have happened was that we prescribed mechanical insufflation and exsufflation to patients with more severe respiratory insufficiency, that possibly symptoms are very obvious at this point, and also peak cough flows can be quite low and unmeasurable with a peak cough flow meter. And that's possibly one reason that there was lower measurements, objective measurements, compared to the manual breath stacking. I looked at the peak cough flow that was assessed on the day of prescribing manual breath stacking. Out of the 37 patients that received manual breath stacking, only 21 had a peak cough flow measurement recorded. On the x-axis, I have the 22 patients, and on the y-axis, the peak cough flow in litres per minute. On average, the average peak cough flow for prescribing a manual breath stacking device was 195 litres per minute. And it ranged from 100 to 350 litres per minute. So you can see there's quite a large range here, and there's no particular trend for prescribing manual breath stacking based on peak cough flow. The peak cough flow for mechanical insufflation exsufflation, we only had 9 measurements on the day of prescribing it. And again, the range is quite high, from 80 to 350 litres per minute, with an average of 175 litres per minute. So the peak cough flow average is lower in mechanical insufflation exsufflation, which would correspond to how we generally prescribe, that we do prescribe it to people with more severe respiratory insufficiency. But again, this large range shows that there's no particular trend here. So I perform SNIP, so sniff nasal inspiratory pressure on every patient that attends clinic, but due to maybe patients being quite symptomatic or time constraints, I might miss a few people. So on the day of prescribing the manual breath stacking, 29 patients had their SNIP assessed. So the average was 42, and it ranged from 12 to 80 in manual breath stacking. And again, a very large range. And no particular trend here either. So you have people with very severe respiratory insufficiency or quite good inspiratory muscle strength. The SNP commencing the mechanical insufflation exsufflation had a lower average SNP at 34, and quite a high range again from 15 to 62. And again, no particular trend. You can see here that there is the lower range was within the manual breath stacking in the previous slide. So moving then on, so there was 9 patients that had both SNP, and they both had peak cough flow assessed on the day of prescribing either manual breath stacking or the mechanical insufflation exsufflation. I want to see, was there any correlation? So you can see here that there's a poor correlation of 0.52 between SNP and peak cough flow. So points of discussion. You can see that there's a small overlap of patients receiving the 2 treatment adjuncts. 30.7% received an airway clearance adjunct. So that's 69.3% of patients who did not receive an adjunct, despite respiratory insufficiency being the number 1 cause of mortality and morbidity, and patients present at diagnosis with respiratory insufficiency. That I think that we're probably missing people. There's inconsistency with the measurements, so particularly with the objective measurements and documentation. And the criteria for prescribing these adjuncts is very unclear. There's inconsistent measurements objectively, and it's very hard to compare these methods. But there was a lower mean SNP and a lower mean peak cough flow for prescribing mechanical insufflation exsufflation. There were fewer peak cough flows for prescribing the mechanical insufflation, and it was based mainly on symptoms. In summary, there's a high physiotherapy demand in motor neuron disease clinic, but however, there's no internationally recognised guidelines for respiratory physiotherapy assessment and management in this population. And the factors leading to this prescription of these adjuncts is not well defined. Future research, mainly really possibly an algorithm or guidelines for the prescription, so to direct physiotherapists in the management of airway clearance management, also looking at quality of life, efficacy, and patient experience using these adjuncts, and finally, patient adherence. But in conclusion, more randomized control trials are required in this area. A lot of the research is based on short-term studies over 2 days, looking at the effects of the mechanical insufflation, exsufflation, and fewer studies looking at the manual breath stacking. So more long-term randomized control trials are required in this area. Thank you.
Thank you, Rachel. Okay, do we have questions, please? Okay, I have one at the back.
Thank you. Emily Plowman from University of South Florida. Thank you for that wonderful presentation. It's really useful data. My area is dysphagia and airway protection, so I really liked what you had to say there. And I was just curious if you have looked at expiratory muscle strength training, which has been shown in other patient populations to improve airway protection during swallowing, cough volume acceleration. It's something that we're looking at, and I was wondering if you guys have thought about that.
No, we haven't looked at that. What devices are you using for strengthening? Or?
And I'll present on it later today after the morning tea. But we use 2 different devices. One's a Respironics device, and the other is from an Aspire 150. Okay. But we noted in our clinic, in about 80 individuals that we did modified barium swallow studies on, only 4% had an effective cough reflex to expel aspirant material from the trachea. 55% had no cough reflex, and the remaining, I think it's 61%, had an ineffective cough reflex. And so we've been focusing on developing techniques to be physiologically guided and have management techniques that help to sort of maintain or even improve that. And we did a pilot study to show that in 15 individuals with ALS, that EMST improved their maximum expiratory generating pressures. Okay. And we're doing a randomized sham control trial now. So. Oh, brilliant! And those, I suppose, that data just shows that we're not identifying enough people really to help with airway clearance management in our clinic. Seeing as we only captured about 30% of patients, so that's quite interesting. Yeah, and I know I'm on the ventilation committee for the Northeastern ALS Consortium, and we did a survey across the United States and found that there's a lot of inconsistencies in the United States with assessment techniques, management techniques. So I think it's great that you're highlighting that. And what assessment techniques do you do in your clinic? Well, it's the respiratory therapists that do the techniques. They do forced vital capacity, MIPS, SNIP. They're the 3 main ones that they do. And how often?
Okay, can we move on and take another question, please? Okay, I have one over on the far side.
Thank you very much for your presentation. I'm Marietta Pollack from Emory University in Atlanta. An algorithm would certainly be useful, but I'm curious about your personal opinion as to when the techniques are best presented. Do you think that you should begin teaching people right immediately after diagnosis prior to any respiratory weakness, or do you have a point after they've started a respiratory decline where you think it's most efficient to begin this sort of training? Yeah, so you can see there with our results that the ranges for initiating the prescription went up to 350 litres per minute. So I would be interested in looking at how patients adhere to treatments if they are prescribed it earlier on in their diagnosis, if they don't have symptoms. So one area, I'm quite interested in looking at the adherence, whether patients, regardless if they have symptoms or not, would use the device. My only reservation is that if patients don't have symptoms, they may not use it. But the benefit of being familiar with the technique and being independent with the technique with the patient and the carer is that, so your peak cough flow might be fine, but then when you get a chest infection, it will drop quite dramatically. So you may have an effective cough one day, but when you have a chest infection, it may be ineffective. And you may be at home without any airway clearance adjunct techniques. So
having a device and being able to use it earlier would benefit patients like that who do get a chest infection. So I do personally, I think patients should know how to use the devices when even before they have symptoms, but doesn't necessarily mean that they're going to use them. But that's why the manual breath stacking is quite good, because it's so cheap. It's only about €20 per patient compared to the mechanical insufflation, exsufflation, and it does have good results in terms of increasing the peak off flow significantly. So that's why I think maybe more research into using the manual breath stacking is warranted.
Thank you, Rachel, for your presentation this morning. Thank you.